Dear colleague, dear friends, it's really pleasure to be with you today and to be part of this great selection of speakers to talk about very interesting topics, which is the deep bite treatment with clear aligners. As you know, the deep bite treatment is one of more difficult cases we do with clear aligners because we know the limit of treatment with clear aligners, mainly for intrusion, and we always to think how we can do in order to manage correctly and to have the right protocol for surgical and non-surgical approach in treating those patients. So today in this presentation, I will talk about a growing patient, I will talk about surgical approach, and I will talk about non-surgical approach as well. Alexandre Besoin. So before to start, I present myself. I'm Dr. Sabouni, orthodontist. I have two practices. My main practice in the south of France, in Bandol. I'm consultant in Dubai, in the UAE. I did my postgraduate in orthodontics in Paris 5 University, and I have some postgraduate in lingual orthodontics and orthodontic surgery. I started with Invisalign in 2007. At that time, it was only for very small, light cases, and today more than 99% of my cases done with Invisalign. And my practice in Dubai called Invisalign Center, and there I do only Invisalign. By the way, it's the only Invisalign center worldwide, and I do only Invisalign there. I'm consultant, as I said. I'm not saying the patient by myself, but I have very good staff to see the patient and to follow the patient there. And my main practice in the south of France, in Bandol. Bandol, it's a very small city, but very nice on the French Riviera between Marseille and Nice. And we have the patient there or people there very, very sensitive to everything aesthetic. So all of them ask for aesthetic smile, for aesthetic appliance, for aesthetic outcome in the end. So for this reason, we try always to find the more aesthetic appliance and more aesthetic way to treat those patients, which is the big interest of Invisalign. So before to start to talk about the deep bite and Invisalign, let's talk about the evolution of our profession, of the orthodontics in the last 20 years. When I did my study, it was in 2001 or 2002. It's not too old, so it's maybe 15 years ago. We had only the plaster model, the X-ray, the pen, and we need to start by collecting all data about the tracing, about the size of each teeth, about the Bolton analysis, and some measure. And when we finish to collect the data that took between 2-3 hours, we start to think about the diagnosis. Then we start to talk about the treatment plan. We know all of us, this guy Burston, to talk about the biomechanic, how we can bond the braces on the right place, then how we can bend the arch correctly in order to apply the right forces and the right moment for the teeth. Today, what changed? Today, when we do our scan and we send this scan to the labs and the technician, like Invisalign, we receive right away or in 24 hours maximum a huge number of information. We receive the setup about the final result according to our prescription. We receive the indicator, the blue indicator, to telling us what movement will be predictable and what movement need to be helped by the auxiliaries or by some other things. We receive the records about the arch form, the record about the overjet, the overbite, before and after, the size of each tooth, the Bolton analysis. So we have a huge number of data without to make any effort to collect those data. So some years ago, we need to collect the data. Today, the data, we have it already. Some years ago, we need to have some time to prepare the appliance, to bend the wire, to bond the bracket. Today, all that will be prepared by the software, prepared by the company. So what we'll do today, the orthodontist, it's the one on the middle of all those data, all those appliances. And our role today is to analyze all those information in order to give our patient the best treatment plan and to adjust the appliance in order to make the movement the most predictable possible for our patient. So it's completely different way to think and completely different way to give the best treatment for our patient. So that's very important to be part of this digital world and to communicate by this way with our patient. And we can see today on the world more than 55% of the population use today the social media and use today the internet by smartphone or by computer. And according to Pierre Lanterne, French CEO of a big company, he said the digital is the main reason over half of the companies, the biggest company on the world, was disappeared since the year 2000. That means because those companies refuse to go for the digital world and refuse to use the new way to work was completely out, and new company came and replaced them. So if we need to exist and if we need to continue to work correctly and if we need to continue to give our patient the best technology, the best treatment and the best result, we should use this technology and use this way for our patient. So today we'll talk about some history about clear aligners, some evidence base about the deep bite treatment and deep bite protocol. We'll talk about predictability and some clinical cases to see some example about all that. So the history about clear aligners, the first experience with clear aligners, it was in 1946 by Kessling. Kessling in 1946, it was the first one create the tooth positioners, the black one, only to align the teeth. It was really the first experience in this field, but it was not really to align the teeth and to have precise tooth movement. In 1990, Sheridan started to think about the real small details when he started to talk about the stripping, and on the plaster model we can cut each tooth and we can make this small movement and create the aligners to align them. So it was the first manual experience in clear aligners. Align Technology in 1997, it was the first company work on this field and to create the digital and to use the CFAO in the clear aligners field. And you know the history of Align Technology and the two students in BA who create this way to treat and this way to digitalize this process of Sheridan in order to have this computerized system and to align the teeth. In France, we started in 2001 and 2015. We have already more than 27 aligner system. Today, I think we have more than 500 aligner system over the world. For sure, Invisalign is still number one since we have more than 8 million patients treated by Invisalign. And the future of clear aligners, in my mind, it will be the 3D printed aligners. The 3D printed aligners to print the aligners directly by ourselves, and all the company will give us only the STL file in order to prepare or to give us the right position. So in each clinic, we print the aligners and we give it directly to the patient. For sure, today we have some limit about the biologic or about the materials, but when we fix those problem, the biologic problem and biocompatibility problems and the flexibility of the materials, in my mind, it will be the future for everything we do. Now, what about the predictability of tooth aligners movement with the clear aligners? So, Horsavi in 2017, he did very nice study. In this study, he saw the vertical movements are more complicated than sagittal and transversal. That means transversal movements, we have enough contact between the aligner and the teeth, it's easy to do it. The sagittal movement, we can distalize, we have the attachment, everything will be perfect. The more complicated movement with clear aligners is the vertical movement. That's mean the deep bite movement. That's mean the open bite movement. In 2009, we needed between 7 to 80% of cases to have some additional aligners. That's mean Kravitz said in 2009, 80% of our patients need another phase to finish the treatment. Today, or in 2018, nine years after, we have another study done by Lanteri, and she said now we need only 37% of cases to do additional aligners. That means the evolution of the system, the SmartForth, the SmartTrack, the evolution of the knowledge of the orthodontist and how use of the aligners reduce a lot the need to ask for additional aligners, and we switched from 80% in 2009 to 37% in 2018. Now, can we do the same quality of treatment between aligners and braces? Yes, we can do the same quality, and we can do this treatment with shortest time when we compare with braces. Now, if we compare the both system braces, fixed and aligners, we can see the braces, it's more effective in the end of treatment to have better occlusal contact, to have more control of the torque, and to have more stability and best retention. Now the clear aligners are much better for all segmented movements and in order to reduce the treatment time. So when we need to have only 2-3 movements, clear aligners much better than braces. When we need to have short treatment and 6 months treatment, clear aligners much better than braces. For all perio problem, for all complicated problem, for sure clear aligners much better than braces. But when we need to have strange occlusal contact, when we need to have more contact for the torque, in this case, for sure, the aligners are better than braces. For the surgery, we can have exactly the same results. According of CANCAM and all in 2019, they said we can have complex surgery cases treated by Invisalign without any problem and with exactly the same outcome than the patient treated by braces. So that's very important. Now talk more about deep bite. So the first question when we think about the deep bite, when should we start the treatment with the deep bite? There is any interest to do this treatment of the deep bite in 2 phases or as interceptive treatment. So as you know, the University of Florence in Italy are very advanced in this field. Tiziano Baccetti, then Lorenzo Franchi did a lot of study about these topics, and they conclude the correction of overbite occurred through dentoalveolar change. With no skeletal modification, though it doesn't make any sense to start very early the treatment for deep bite patient. So the best moment to do this treatment for deep bite patient, it will be between CS3 and CS4. That means during the puberty time, and doesn't make any sense to start at 6 or 7 years old the treatment for deep bite patient, since it's only dental alveolar change. So we don't need to have any skeletal modification to correct for the deep bite patient. So the patient treated at puberty showed high prevalence rate of corrected of overbite during 1 year and 92% of stability. Now, I found only one article talking about the management of overbites with Invisalign appliance. This article published in 2017 in American Journal of Orthodontics, and one of the authors, it was Sam Daher, one of our friends, very experienced orthodontist with Invisalign, and some other friends from the University of British Columbia. So in this article, they selected 3 different practices, and they asked them to describe their protocol to treat deep bites. So the first very interesting things, each orthodontist has his own protocol completely different with the others. That's mean the Invisalign, when we talk about clear aligners and Invisalign, we cannot talk about technique or about one unique protocol, since each orthodontist has his own protocol, and all of us, we complete by using the clear aligners by our way in order to provide the best result of our patient. So in the conclusion, as conclusion in this article, we conclude the Invisalign can treat the bite patient with a very good way, and the primary mechanism to treat the deep bite is by incisors movement. That means we can make some protrusion, proclination of the incisors to treat the deep bite, and Invisalign appears to manage the vertical dimension relatively well, but when we work on the upper incisors. Now, very interesting article about the accuracy of tooth movement with clear aligners. And this article published in 2018. In this article, we compare around 300 or 400 cases, and we study movement by movement, tooth by tooth, all movement predicted in the ClinCheck, and we compare the results by what we get clinically on the retention and the end after this phase of treatment. So we compare all measure we had before and everything we get. And as a result, we have the average of predictability. It was between 70 to 75%, so that's fine. But some movement, very difficult movement, like the intrusion of anterior teeth, the upper incisors, and the rotation of the canine, we get very small predictability for them. And you can see here for the maxillary central incisors, we had on the middle 1 millimeter intrusion, and what we get, it was 0.25 extrusion. That's mean we plan to have intrusion and we get extrusion. So that's mean that's very difficult movement, the intrusion movement with clear aligners, and we should be very careful how we can make this movement doable, and the aligners only cannot be the best appliance to do the real intrusion movement. And in this article, we conclude the two less accurate movement, the most inaccurate movement is the intrusion of the incisors and the rotation of the lower canine. What about the surgery? One of the very nice article about the orthodontic surgery and the clear aligners and braces, it was written by William Prophet on the occasion of the 100 years anniversary of the AGO. And he talked about the deep bites by saying, in short phase deep bite patient, it is best to simply align the arch and to do the preparation only by the align of the arch without any pre-surgery leveling of the lower incisors. That means we don't need, for the preparation for the orthodontic surgery cases, we don't need to level the curve of Spee. We don't need to intrude the lower incisors. We need only to align the teeth very quickly. Then during the surgery, we can make some rotation of the lower jaw, so we can increase the height of the lower face, and we can prepare the surgery without to need to go for the complicated procedures. Now, Willie Dayan from Canada, who want to talk a lot about the biomechanic, he said the use of aligners is far more complicated than most people believe. It takes a knowledgeable clinician with considerable experience to use this appliance to its maximum. What's the maximum? He don't know. He doesn't know because it's very open as a system, and there is no limit for what we can do with clear aligners. We can treat 100% of cases when we have enough experience, and for sure if we have compliant patients. The only things we need to think about, the aligners need to push the teeth on the final position. It's completely different way to move the teeth than braces. The braces pull the teeth to the final position. The aligners push. And in order to push, we need to have contact. So everything we need to think about how we can create the contact between the aligner and the teeth. When we have the contact, the aligners can do the movement and can align the teeth without any problem. Let's go for some clinical cases. So the first patient I wanted to share with you, it's the patient of Emily. Emily, 7 years old when she came to us. She came, as you can see, short face, big class 2, the lower jaw is too much back, we have lip interposition, and we have proclination of upper incisors. We can see here the intraoral photos. We have some protrusion of upper incisors, some protrusion of the lower, and we have very narrow arch form. So for sure, if we need to correct the deep bite, for now it's too early because we have the time to correct the deep bite. If we need to correct the class 2, it's very early because very far from the puberty time. We are between CS1 and CS2. That means we need 3 or 4 more years before the accelerated growth time when we can correct correctly and quickly the class 2. But we should do something for this patient. Why? Because if we leave this patient without correction, this protrusion of upper incisors will create very big risk to have traumatism of the upper incisors and to have very big risk to have the problem of the teeth. And since we have the lip interposition between upper and lower teeth, the lower jaw will still completely back, and we lock completely the growth of the lower jaw. So we need to do this treatment not to correct everything as deep bite and as class 2. We need to make it only the unlocking of the growth. We need to leave the upper and lower jaw grow correctly for the next phase. So for this patient, we do this treatment using Invisalign first and using the mandibular advancement feature. So during this time, what we did, we intrude lower incisors, intrude upper incisors, and we plan to have the advancement 2 mm by 2 mm. It was only 50 aligners, which is around 50 weeks. This less than 1 year, the whole treatment time, and we can see what we expected to get as results. We can see the evolution of treatment, and we can see what we get on the end. What we get, we correct completely the protrusion, we correct completely, we improve the deep bite, we create some posterior open bite, which is normal, which is what we're looking for, and now we can leave the patient the time to have all permanent teeth to start the second phase. So the first phase, we don't need to correct everything. We know that it's not the right time yet to correct perfectly the deep bite, but what we need to make the unlocking. We need to keep the upper jaw completely, and we need to leave the lower jaw grow correctly and without any pressure of the upper jaw. And here we can see after 1 year, patient smile after treatment, and we can see the profile evolution after treatment. So this case, it's the patient before the puberty time. This patient, it's between 6 to 9 years old. The protocol, it's only to go for unlocking. Unlocking for the sagittal malocclusion and unlocking for the vertical malocclusion. The only things we should correct at this stage, it's the transversal malocclusion. We make the expansion correctly, that's very important, but for the sagittal and vertical, we need only to do the unlocking. And we can see the result. We improve the deep bite, we improve the class 2. We didn't correct it completely, but we stay in 1 year treatment, not more. And we have another phase in the future to finish. Now, when we start the treatment during the pubertal time, like Ines 12 years old, so now the right time to correct everything. And when we see the X-ray for Ines, we can see the curve of speed. So in this case, what we need to extrude all posterior teeth to have the curve of speed perfectly straight. So how we can do? We can see the intraoral photos. We have the profile with the class 2, short face, and we have some crowding for the upper and lower teeth. On the X-ray, we can see the B retrusion for upper and lower incisors. We can see the cephalometric analysis, and we can see the ClinCheck. In the ClinCheck, we have 33 aligners. We put here the bite ramps in order to create the posterior open bite. We have the power ridge in order to apply the torque of the upper and lower incisors. Class 2 elastic to stimulate the growth of the lower jaw. And I asked to cut the aligners behind the second molars. So we have the second molars completely free to extruded. So we had the bite ramps, the power ridge, the class 2 elastic, and the aligners stopped behind the first molars. So the second molar will not cover by the aligners. 33 aligners, which is around 7 months. On the end of these 7 months, what we get this result. That means we had contact between the incisors and contact between the second molars. And we have lateral open bites. What we need now, it's very easy now to only extrude the teeth on the middle to close this lateral open bite. How we can do that? We need cut out button and elastic for the molars and attachment for the premolars. And we can see here the ClinCheck for this phase. So elastic, extrusion, and we close completely this phase. and we can see the final situation. So we can see the elastic as in triangle between upper and lower molars, and we can see the class 2 component as well in order to improve the class 2. Here, the final intraoral photos on the end of treatment, we can see the retainer, and in the end of treatment, the fixed retainer to finish the case. And when we compare the X-ray before and after, we can see the perfect leveling of the curve of SPIE in the end of treatment and patient smile on the end of treatment. So these patients, it was the right time to correct everything. So we did the treatment in one time and we focused to correct everything. That's mean we focused to correct the vertical, the sagittal, the transversal, and we finished the treatment on the perfect way. The first patient, it was too early. We did only the unlocking of the lower jaw and we wait the second step to finish the treatment. Now, 15 years old, a little bit more far. Marie came to us without big growth. Now we finished already 90% of the growth for Marie. We can see when we see her smile, we can see the gummy smile. So if we talk about the deep bite for this patient, what we like to do is to try to intrude upper incisors in order to improve her smile. We need to improve the profile as well. We can see the profile is short face and class 2. And we need to improve the alignment of the upper and lower teeth. We can see on the X-ray, the growth already done. We are between CS4 and CS5, so have very small growth still to use. And we have all permanent teeth are present here, except the second molar on the left in progress. We did the cephalometric analysis. We can see B retrusion or retrusion of the upper incisors, protrusion of the lower, and small class 2 degrees. So it's very important when we think about such cases, it's to think how we can do to use the class 2 elastic in this case in order to improve the vertical malocclusion. That means it's very important in such cases to use the vertical component of our elastic in order to improve the vertical malocclusion. We know here we have the center of resistance of our maxillary. And what we're looking to do here in this case is to intrude the upper incisors to improve the deep bite. So by using the elastic through this center of resistance, that's mean using class 2 elastic between the first premolars and the canine, or between the first and second premolars, that's mean we have the force line through the center of resistance of the maxillary. And in this case, we don't have any vertical movement of the upper jaw. Now for the lower jaw, we try to use our class 2 elastic as back as we can. So in this case, we will have the vertical component in order to create posterior rotation of the lower jaw, which is what we're looking for this patient since we have short face. So in this case, for the deep bite strategy treatment, we ask to intrude the upper incisors and we ask to have some posterior rotation of the lower jaw. The combination between the posterior rotation of the lower jaw and the intrusion of the upper will give us the full treatment of the deep bite for this patient. So we can see the clean check. Intrusion of the lower incisors, distalization, intrusion of the upper, and small jump on the end for the small growth still on the end of the growth. So we can see the distalization of the molar, proclination of upper incisors. I upright, distalize, then intrude, close the space, and small rotation of the lower jaw. So we can see the intraoral photos on the end of treatment, perfect fitting of the aligners, and we can see the final situation and the end of treatment. Class 1 right and left, the deep bite completely corrected, and we have very good alignment without any additional aligners. And we can see the perfect improvement of the deep bite, perfect improvement of the gummy smile, and for the profile as well. So that's very important. It's to use the right protocol, to use the right elastic position in order to improve the the deep bite and the class 2 for our patient. And we can see what we get exactly. So we superimpose before and after. We can see how we intrude and derotate the lower jaw simultaneously for this patient. And patient smile before and after treatment. So if we summarize the treatment for growing patient, first things, doesn't make any sense to have 2 phases treatment for deep bite, but some cases we need to do. So as the University of Florence said, we don't need to have 2 phases treatment, so only 1 phase it's enough. But in some case, we can make some unlocking of the lower jaw. If we have any lock to the growth of the lower jaw, we should do this treatment. The aligner by trumps, it's very helpful in some case. As we see with the aligners by trumps, we can create posterior open bite, and sometimes we can cut the aligners behind the first molar, so the second molar can extrude and we can create the posterior open bite. So the key, if we need to correct the deep bite by extrusion of the posterior teeth, we need to create this posterior lateral open bite. By creating this lateral open bite, we can extrude the teeth and we can correct completely the deep bite. The intrusion of anterior teeth is done by pressure area. As I said, for the growing patient, this pressure area on the upper incisors can create very effectively intrusion of the upper incisors. For adult patients, it's a different story, but for growing patient, as we see for the last patient, it's creating this pressure point on the incisors. It's very helpful and very powerful to intrude upper incisors. And in this case, we have only posterior attachment, encourage attachment to maintain posterior teeth, and we have the pressure point and the pressure area in order to intrude anterior teeth. And the last point, it's the class 2 elastic should be combined with the vertical right position in order to use the vertical component on the right way. That means when we use the class 2 elastic, we should to use this elastic on the right place in order to use the vertical component of this elastic to make some rotation of the lower jaw or not rotation of the upper in order to improve the deep bite for our patient. So these are the 4 points we need to understand for growing patient. First point, the treatment of the deep bite should be in 1 phase during the puberty time. Second phase, if we need to improve, if we need to level the curve of Spee, we need to create the posterior open bite, and that we can do it by the bite trumps, or we can do it in some time by our bonded bite trumps. Third point, if we need to intrude upper incisors, we have the pressure points very effective, and we can intrude the anterior teeth with clear aligners, and we can use the bite trumps in this case as well. It's very effective. The vertical effect of the class 2 elastic could be used as well in order to improve the correction of the class 2. So that's the growing patient. Now let's talk about the adult patients. For the adult patient, I did some study with my friends Alessandro Greco and Thomas Dreschler about views how we can use correctly the G5 treatments or G5 features for growing patients. So if we need to use Invisalign, with Invisalign, when we talk about clear aligners and deep bite, we have these 3 points we need to know. The first one, we have the bite trumps. The bite trumps here, up to 3 millimeters, could create contact between upper and lower incisors. This contact is very helpful to create posterior open bite, to extrude posterior teeth, and to create vertical forces of upper and lower incisors to help the intrusion. The second things with deep bite, we have here the attachment, deep bite attachment. Those deep bite attachment very helpful. First, to maintain these teeth in place during the intrusion, and second, to extrude those premolars at the same time when I intrude anterior teeth, so we can perfectly level the curve of Spee. And on the end, we have the pressure point. The pressure point here, as I said, we have the pressure surface on the labial and pressure point on the lingual. When we have the combination of the surface and this point on the lingual, we can orient the intrusion force during the ground axis of the teeth. So we can see here the biomechanic of the intrusion of clear aligner with Invisalign. It's the pressure points here and pressure area on the labial, and we can have perfectly intrusion movements mainly for growing patients. And when we use the bite ramps, these bite ramps will create posterior clearance on the between upper and lower teeth, and this posterior space will be used to extrude posterior teeth and to help for leveling of the curve of Spee. The only things we need to know about those bite ramps, it's the limit of these bite ramps is 3 millimeters. So if we have 4 or 5 millimeters overjet, these bite ramps cannot be enough to create this posterior open bite, and we need in this case maybe to put these bite ramps on the canine or to bond the bite ramps by ourselves. In this case, we can use the mini mold or we can use the turbo bite to create before the scan the bite ramps, then we can receive our aligners with the customized bite ramps. So if we need to have a protocol to correct the deep bites, for short face, it's more than dentoalveolar than skeletal. So when it's dentoalveolar, it's one phase treatment. We need to have the bite ramps or we need to have the bite ramps done by ourselves with the mini mold. If it's skeletal short phase and we need to improve it, in this case for growing patient we use the functional appliance, and for adult patient we go for orthodontic surgery. For long phase, if we have up to 2 millimeters, we can do with some relative intrusion. That's mean with some inclination. If we have more than 2 millimeters, we need to have TADS to have real intrusion. So that's all the way when we need to correct the malocclusion for the bite patient. So again, if we have short face, when we have short face, that means we need to level the curve of Spee. If we need only to work with dentoalveolar movement, in this case, we need only to create the posterior open bite. To create that, we have two ways. We have the bite ramps or we have the mini mold and the bite ramps doing by ourselves with the turbo bite. So even the bite ramps included on the aligners or the bite ramps bonded on the teeth. If we have skeletal short face and we need to correct skeletally the short face, in this case, we can use functional appliance or we can use the orthodontic surgery for the adult. For long face patients, we have deep bite up to 2 millimeters. In this case, we need only some proclination of the lower incisors, which is very easy. If we have more than 2 millimeters deep bite, in this case, we need to use TADS and to have real intrusion and class 2 elastics. So again, we can go for adult patient. So if we go for the adult patient, let me show you an example. It's this patient. This patient came to me in order to improve her smile. As you can see, fully deep bite. She had an orthodontic treatment by aligners in another clinic, and she came to me in order to ask if the case is done and she's ready to go for the retainer, or if we need to do any other step before the retainer. So I asked her to come with the clean shake and all the photos. We can see the clean shake she had during the first phase. As you can see, 69 aligners for this treatment. So I saw the aligners the fitting of the aligners was correct on the aligner number 68. That's mean we have except some misfitting for the lateral incisors. Everything was good. I asked the patient to remove the aligner, so she wear the aligner number 68, which is the one before the end of the treatment. I asked her to remove these aligners, and we can see the result. So I compare the aligners and the teeth, the photos before and after. We can see after 68 aligners, after 30 months of treatment, the patient was exactly on the same results. So what's happened for this patient to have this filler? I try to analyze this filler for this patient, and I saw first the elastic was used. It was very heavy elastic. It was 6 Oz elastic, and this elastic was hooked on the aligners directly. That means we had hooks on the aligners, pushing the aligners completely on the back. So by using this very heavy elastic with these sagittal forces, we cannot ask the aligners in the same time to upright the upper incisors. So for this reason, we didn't correct completely, or we didn't improve the retroclination of the upper incisors. Second things, using the elastic on the canine, we are more forward than the center of resistance. So we have huge vertical components to create this anterior rotation of the upper jaw. And third things, I check here the staging of the class 2 correction. So the staging was very quick for this patient. So since the staging was very quick, we didn't get any correction of the class 2. So the first error, it was about the position of the elastic. The second error, it was about the forces of the elastic. The third error about to use the elastic on the aligners and not on the buttons bonded on the teeth. And the fourth error, it was by using the wrong protocol. And the last error, it was to use the aligners in the extreme limit. That means we know with the aligners we can distalize maximum 3 millimeters. When we have 5 millimeters class 2, we know we have already on the maximum of the limit. When we need to intrude the anterior teeth more than 1 millimeters, we know the limit of the aligner is 1 millimeters. When we have 3 millimeters to intrusion movement, we know if we need to have this movement predictable, we need to add mini screw to help this movement to be done. So without to have that, for sure we go for this filler. So when we analyze and we think how we can do to avoid it, I discussed with the patient and I gave her a new proposal for the treatment plan. And I try with this proposal to remove all the bad things during the first treatment. That's mean, look what I did. First, I used the elastic from the premolar inside to the molar outside. So I don't push the aligner on the back. Second things, I use the elastic on the second molars to create some vertical components of the aligners. Third things, look how I did here for the anterior teeth. I did here the space closer on the anterior teeth in 2 stages. That means I start by distalizing of the premolars, then I start the canine only 2 millimeters, then I stop, I close the space for the incisors, then I start again the canine, then I start again the incisors. That means I did this treatment in 2 phases. By doing that, I avoid to have the repeating of upper incisors. And I ask to put 2 mini screw to intrude the upper incisors. So the combination between the right protocol, the right staging, the right elastic, the right position of the elastic, the using of the mini screw on the same treatment plan, we can go and we can get something much more predictable for our patient. So for sure, the elastic will be here between the aligners and the mini screw on both sides, and we can see the result before and after. The class 2 corrected, the deep bite corrected, and the alignment is much better. And we can see the patient smile after treatment. So for all deep bite patients, if we need to improve the smile, the only way is to go for intrusion of upper incisors. And that's the case of Michael. Michael had orthodontic treatment in the past and had veneers on all his anterior teeth. If we check the X-ray of this patient, we can see he's a deep bite patient and short face. So we think the best way, according of the X-ray, is to extrude posterior teeth. But if we check the smile of this patient, we can see the gummy smile. So we don't need to check and to decide our treatment plan only according of the X-ray. We need to do it according of the patient's smile. So according of the patient's smile, we decide to go for the treatment to intrude anterior teeth in order to have the smile line much better. Now, if we need to intrude the anterior teeth, we know the limit of the aligners only it's 1 millimeters. If we need to go more than 1 millimeter, the only way is to have mini screw. So we can see the clinic for this patient. So distalization, during the distalization, I applied upper incisors, then I intrude them to have them perfectly straight. 36 aligners, and we can see the 2 mini screw and the elastic between the aligners and the mini screw. So we create inside the aligners 2 cuts, and we connect this cut out with the mini screw in order to improve to intrude all the teeth. So we can see the final situation without any additional aligners, and we can see patient smile. So we did this treatment plan according of the patient's smile in order to have the smile line perfectly accordingly of the patient's smile. And the X-ray before and after treatment. So let me show you this short video about the procedure, how we put the mini screw and how we put the elastic. It's really simple, really easy, and we should do it by yourself. As you can see, it's really easy, really simple, and we can push the limit and we can treat all intrusion movement with very big efficiency. Now Christine, very nice patient. She's the mother of 3 of my growing patients. I treated them over 4 or 5 years. Then she came and asked if we can do something for her in order to improve her smile. As you can see, a gummy smile, deep bite, narrow smile, and we have some retrognathic of upper and lower jaw. So I told her, for me, the best option is the orthognathic surgery. She said, yes, I know, but I don't want any surgery. And if we cannot do anything for me, that's fine. I'm happy with my smile. It's not a big issue for me to stay as it is. So I told her, no, I will try to do something without any surgery. I did the X-ray. As you can see, we have B retrusion of upper and lower jaw, long face, and we have big crowding of the upper and lower. We have agenesis of the tooth number 1.2, 1.3, and on the left side, we have the tooth 2.3 completely mesialized, and 2.4 are agenesis of 2.4 as well. So we have 3 missing teeth on the upper jaw. and we have big crowding of the lower. Cephalometric analysis, we can see the retrusion, 7.8 degree retrusion of the upper incisors, and we have 2 degree retrusion of the lower, and we have class 2 around 7 or 8 degrees. The intraoral photos, we can see here we have very big crowding of the upper and very big spacing and deep bite and shift of the midline on the top. What is the best treatment plan? So when I see this patient I treated, I think in 2009 or 2011. So at that time we had not the ClinCheck with 3D control. That's mean all modification at that time, it was done by the technician. So we should, for all small modification, write for the technician and send a message in order to do the modification. So for this patient, the first treatment plan, I ask the technician, please make the extraction of 34 and 44 and open the space for 2 implants on the top, 1.2, 1.3, then mesialize 2.3 and open the space for 2.4. So that was my first opinion about this treatment plan. After 3 or 4 modifications with the technician, I received a good treatment plan. I asked the patient to come to explain her this option. So the patient was happy, but she said, okay, look, it's very nice, but I'm not willing to remove 2 premolars. If I have already 3 missing teeth on the top, it's not to remove another teeth on the lower. So I prefer to avoid that. So if you have another option, please don't hesitate to contact me again. So I work again with the technician and try to find another solution. And I ask the technician to remove only 1 lower incisors, which is the 42. By moving the 42, we have only 1 missing tooth, so we can have something easier and something simpler for the patient. Maybe she will accept it, and ask to have some protrusion and some stripping in order to compensate. I received the ClinCheck after 3-4 modification. I was happy with this ClinCheck. I asked the patient to come and I show her the new ClinCheck. So she said, that's fine, but as I said, I don't want any extraction. So again, I asked the technician, please have some new project without any extraction, only expansion and alignment and stripping. So another 3-4 modification. And I received very nice ClinCheck without any extraction with 80 aligners. I asked the patient to come. I show her the ClinCheck. The patient was very happy and she said, look, if you want, we can do it. And now I'm very happy with this ClinCheck. How long the treatment will be? So I told her we have 80 aligners, which is 40 months. At that time, we changed the aligners every 2 weeks. So the patient, when she saw this treatment time and this 4 years treatment, she said, look, that's very nice, but for sure I cannot. It's too long. I'm okay to do the treatment for 2 years, but not more than 2 years. In this case, I was completely disappointed because I did a lot of effort in order to give her the good treatment plan, and the patient always refused. The case was very interesting for me because it's the first really complicated cases I treated at that time. So I contacted the dentist of this patient and told her, look, after 2 months working with the technician of Invisalign, the patient's still refusing this treatment. Do you have any idea we can do? So he asked me why with this treatment is so long. I told him it's because we need to open the space for 2 implants on the right, and in order to do that we need to distalize all the teeth to put it in class 1, and for this reason that take at least 80 aligners. So he gave me a very good idea. He said, why we need to open the space for 2 teeth, why we don't open the space only for 1 tooth on the right, and on the left side, why we need to mesialize the 2.3, why we don't keep the 2.3 in distal, and we open the space only for 1 implant, it will be another 2.3 in mesial, so we have 2.3 and 2.3 bis. So I try to do this option, and in the end I get only 50 aligners, and I told the patient, look, I find finally the position with 2 years treatment and with only 2 implants on the upper jaw. The patient was very happy and she accepted this proposal. So we can see the treatment plan. as you can see, expansion, alignment, intrusion of the upper incisors, and proclination of the lower. In order to get that as a result, we can see the final result exactly as we expected in our CleanCheck, in our treatment plan. So we can see how we can do this treatment. We use 2 mini screw. So at the beginning, we use the mini screw from inside to outside. That's means from inside the aligners, we did the 2 hooks to the mini screw. Then from outside, we have the cut-out buttons to the mini screw in both sides in order to intrude the teeth. So everything was good, and we can see the final situation on the end of treatment. We can see the X-ray before and after. We can see the proclination of the lower incisors. We get to compensate the no extraction, the complete correction of the axis of the upper incisors, and we can see the final smile of this patient. So for sure, it's still not ideal treatment. For me, it's the best compromising treatment we can give for this patient. For sure, the best treatment is surgical treatment for this patient. But as compromising treatment without surgery, I think that the best treatment we can think about this case. Because we improve the smile, we improve with the good alignment, we expand the smile, we do a lot of things without surgery. And for sure, with the braces, it's impossible to do this treatment. So thanks of the aligners and the mini screw, the elastic, the compliant patient, we get very good results on the end. And the very good things with the aligners, we can ask as much aligners as we want. We can ask as much treatment plan as we want. We start by treatment plan with 2 extraction and 4 implants, and we end up with treatment plan with 2 implant and 0 extraction. So that's the good things of Invisalign. We don't need from the beginning to decide about everything. The first treatment plan, it's always the treatment plan for diagnosis. Only the treatment plan for study the case. I collect the data, as I said, I do the prescription, I receive all the data from the system, then I start to think about this case, what is the best treatment, and I can discuss with the patient. So today it's a bit different because we don't need to have this 10 modification with the technician. We can do everything by ourselves. With the 3D control, we can prepare, we can manipulate the software, and we can use exactly the right position by ourselves. Sometimes ago, we should use the technician to do all modification, and each time we need to ask the modification that took between 2 and 3 days. So it was too long. Today, in 2 hours, we can do exactly the same 10 treatment plan, but doing by ourselves. So this patient was very happy, and she said, look, you are really changed my life. I really trust you. Now you did my 3 kids, you did my smile, and now I need to refer you my husband. So she referred her husband, Serge, 50 years old. He came with very similar requests, the same deep bite. So I asked him to smile to see his teeth. So he's never smiled when he came, was always the mouth completely closed. So when he smiled, we can see the position of his teeth. So huge deep bites, huge crowding of the upper and the lower, and the problem, the perio conditions in this patient was completely different than his wife. That means for his wife, the gum was good, the teeth was in the healthy condition. In his side, he's very smoky, and we can see in which condition we start this treatment. So I told him, look, if we'll do the same thing as your wife, that's mean if we don't need any extraction, if we don't need anything, I prefer to avoid to do this treatment. If you follow my recommendation, in this case, we need to start by big cleaning, scaling, clean everything and stabilize the gum conditions. Then we need to remove, we don't have any other option against to remove 1 tooth, because I cannot procline, I cannot make any big movements since we don't have enough bone around of your teeth. So he accepts, he said, okay, look, I can do what you want. Now I trust completely your judgment and your opinion since I saw what you did for my wife. So I can follow your recommendation and your treatment plan. So we decided to remove the 42 for this patient, to distalize the teeth on the right and on the left to have the full class 1, and to keep the space on the right for 1 implant. So on the left, we close completely the space by distalizing the teeth. On the right, since we are already in class 1, so we keep the space to put 1 implant. We can see the X-ray. We can see the B protrusion of the upper and lower incisors, and we can see the bone level very low since we have the periodontal problem for this patient. Cephalometric analysis, we can see the retrusion of the upper incisors 17 degrees and the retrusion of the lower incisors 4.3 millimeters, which is around 11 degrees as well. So we can see here the clean check. So in the clean check, you can see what we plan. Protrusion of the upper, protrusion of the lower, clothing the space on the left by using the power arms since I need to control the axis of the teeth, and opening the space on the right in order to put the implants. So extraction of the 42, correction of the midline, clothing the space, alignment of the teeth, and opening the space for the 2.4. Patient following perfectly the treatment plan, and we can see what we get on the end of the treatment. Class 1 on the left, midline, and opening space for the 2.4, 1.4. We can see the space closer, we can see the power arms, and we can see the final position when you close the space. And here the final position of the end of treatment and the final position with the implants. Patient profile before and after treatment, and patient smile before and after treatment. So both patients are very happy to have the final result. We still in the compromising treatment for sure, but the other option for this patient, it was to remove all his teeth and to go for full mouth implants. It was the second option for this patient, and I think thanks to Invisalign and thanks for this management of the treatment plan, we avoided completely the extraction, we avoided completely the implants, and we keep all his teeth, and we get a very nice result for this family. Now, so the two first patients, it was long-faced patient and intrusion patient, which is easiest case comparing of the deep bite short face patient, because short face patient we need to extrude posterior teeth. So when we need to extrude posterior teeth, it's much more complicated because we need to find a way to create the posterior open bite. We need to find a way in order to create this clearance between upper and lower teeth on the back. So Stefan, 60 years old when he came to us. As you can see, very narrow smile, fully deep bites, a genesis of 12 and 22. We can see big retroclination of the upper incisors and the lower incisors. So what we can do in order to correct the deep bite for this patient? What we need is to open the bite. If what we need is to extrude posterior teeth, but in the same time, we can intrude a little bit anterior teeth. So what I plan as treatment plan for this patient, it's to extrude, to procline upper and lower incisors. But proclining the upper and lower incisors, we do the relative intrusion for those teeth. And I use at the same time class 2 elastic. Those class 2 elastic, in the same time when I do this proclination, will advance the lower jaw, and that will create anterior interferences. So I had the bite ramps, I had the B protrusion, I had the class 2 elastic, so I create the posterior open bite by these anterior interferences. Then I extrude posterior teeth by using button and elastic in order to close this posterior open bite and correct completely this open deep bite. So again, proclination of the upper, proclination of the lower, class 2 elastic, some distalization, and then in second phase, extrusion of the posterior teeth. Let's see the clean check. So we start in this phase. Look what I asked to do. Bite ramps, class 2 elastic, proclination of the upper, proclination of the lower, opening the space for 1222. And as soon as we finish this phase, I start the second phase. And look, when I start the second phase, I had already the posterior open bites. That's mean the deep bite already corrected. I get a lot of posterior space, and what I need now, it's only to close those space by extrusion of posterior teeth, and that's it. Again, for the other side. So the second phase, only small distalization in order to correct the space. And again, the first clean check. So the first clean check, I start here, and you look what I get. Because when I procline the upper incisors and using the class 2 elastic for class 2 deep 2 patient, I have the unlocking of the lower jaw and have the natural advancement of the lower jaw. So the deep bite was corrected by this shift of the lower jaw. Then I had only some posterior open bite to be corrected. So look the clean check for this phase. Proclination for the upper, proclination for the lower, and opening space. Why I decided the opening space? Because since I need to open the space, I need to create volume, I need to protrude upper and lower incisors. So that was the best option. And I had, as you can see here, the bite ramps in order to create the posterior open parts. So we can see we started in this phase, distalization, expansion. And we can see what we get on the end of this treatment and the final results. We have the implants for 12 and 22, the deep bite completely corrected, and the patient is very happy to get this final result. Patient smile on the end of treatment, and patient smile before and after. So now if we need to summarize the treatment with clear aligners for adult patients. First things, it's very effective and faster than the treatment with braces, the treatment of deep bite with clear aligners. Second thing, the power rich, very helpful to make the torque movements and to procline the teeth in order to get the relative intrusion. Third things, if we need to intrude, to have real intrusion of anterior teeth, in this case, we need to have TADs. So if we need to have relative intrusion, we need only the power ridge with the aligners will be enough. The real intrusion, the TAD, it's very, very helpful. Now, if we need to increase the posterior height, if we need to correct the deep bite by extrusion of the posterior teeth, in this case, we need to have the bite ramps, and on the posterior, we need to have cut-out buttons and elastics. So by using this cut-out button and elastic, the bite ramps, we can create the posterior clearance, and we can create this posterior open bite, and we can extrude the posterior teeth to flow this gap and correct that. So that's very important. We cannot correct the deep bite by extrusion of posterior teeth if we not create this posterior gap. So to create this posterior gap, it's very important to have these bite ramps and to have this space creating before. We can use overlay, we can use a new crown, we can use what we want, but the idea, if we need to extrude posterior teeth, it's try first to create posterior clearance between the teeth in order to help them to move down. Now, the last part of this conference is to talk about the surgical approach. So we started by growing patient, and we decide for growing patient according of the patient age, if we need to start early or not, and we decided to not do this treatment very early, since the growth or the correction of the deep bite is more by dental alveolar movement than with the skeletal change. Then for adult patient, we saw we need to use on the most cases, we need to use mini screw and elastic in order to have more effectiveness to ensure the teeth. Sometimes we need to go for the surgery on some complicated cases, mainly when we have really severe deep bites. So let me show you the case of Remy. Remy is the son of Stefan, the last patient. So he saw the treatment of his father, and his father was very happy. So he came and he said, look, I had an orthodontic treatment for more than 2 years and they removed 4 teeth. And now when I smile, we cannot see my teeth. So I saw the smile of my father. Do you think we can give me the same smile and we can go for the same things? So I did the intraoral photos. As you can see, very short face, narrow smile. And when he smiled, even when he have a big smile, we can see only 2 or 3 millimeters of his teeth. So I told him, the problem, your father has 60 when we did this treatment for him, and you are 18. So I don't try to have the same treatment plan, and your father has 2 missing teeth, so we open the space. He hasn't any orthodontic treatment before. You had an orthodontic, we remove premolars. I don't like really to add another implant, and to open the space we created with this surgery. So I prefer to go for the treatment with surgery without to reopen the space for implants, and we need only to advance your upper and lower jaw and to create the right height of the lower face. So with discussion with the patient accept this treatment plan, and we decided to go forward on this option. So what we decided is to have short preparation. So what the preparation, remember the study I showed you, or the article of Profit. And this article, he said, we don't need to level the curve of Spee for short face deep bite patient. That's mean this patient, as preparation, what we need, it's only to close this space and to make some expansion. That's it. So we started by this preparation, only 6 months, small torque for space closing. And after 6 months, the patient was ready to go for the surgery. The position of the surgery, it was this position without any leveling of the curve of Spee, without any correction of the deep bites. So what I did, I put only some bite trumps with my mini mold, with the composite behind the teeth, and I did all my 3D analysis. I used Dolphin imaging software. I did the cephalometric analysis. I did the 3D X-ray, the 3D intraoral scan, the 3D photos. I combined 3 of them. Then I did the virtual surgery. So I select the Lefort one, then I select the lower jaw surgery. I make the advancement 5 millimeters of the upper. I prepare the first split the surgeon will use during the surgery. Then I advance the lower jaw and I prepare the second splints. It's 2 STL file. I export them to my labs and I print them with my 3D printers and I gave them to the surgeon. And you can see here the position on the end of the surgery. That means I plan to have only contact between upper and lower incisors and the second molars on the top and the bottoms, and to have posterior lateral open bites. So this position is the final position on the end of the surgery. So when we go for this surgery first with short preparation, it's very important to provide the guide, the surgery guide. The surgeon will use this template the surgeon will use during the surgery to know exactly what is the final bite we need to get on the end of this treatment. So as I said, I put it here the bite ramps by ourselves before to start this, to go for this surgery. The surgeon put the plaque and the screws to block the upper and lower jaw. And we can see the position, the advancement of the lower jaw, the vertical elastic in order to extrude the lateral teeth on both sides. And we can see the final position after 4 months of the surgery. So the whole treatment procedure, it was only 6 months. And the secret of this surgery, it's don't intrude lower incisors. Only do this treatment with decompensate on the transversal malocclusion. That's it. When we finish to decompensate on the transversal, we do the advancement and the derotation of the lower jaw, then we have another phase to extrude posterior teeth, and that's it. We can see the patient smile after treatment. The profile is much better, the smile completely different, and we can see the X-ray before and after treatment, patient smile before and after treatment, and patient profile before and after. For sure, this patient, we cannot get such nice result without orthodontic surgery. That means if this patient, we did the same treatment plan as his father, and we decided to go for the treatment without surgery, for sure we can get good alignment. Maybe we can correct the deep bite by extrusion posterior teeth, but we cannot get such nice profile, such nice smile, such nice balance between upper and lower jaw. So we should take the right decision according of the patient age, according of the patient objective of this treatment, why this patient come to us. If this patient wants really to have a big change on his profile, big change in his smile, for sure that's the best option. We cannot go for the option we do by doing only the alignment or only some intrusion. No, we need to have a real correction and real option, which is the orthodontic surgery. And we can see the difference between the both treatment, the treatment of the father and the treatment of the son. This before treatment, both of them, and this after treatment, both of them. We can see before and after. So both of them are very happy of the final result, but two completely different way to get the results. Treatment time 2 years for the father and 1 year for the son. Deep bite corrected by both of them, but I think the result we get for the son is much more stable, much more nice, much more aesthetic than the treatment we get for the father. But according of this age, I think the surgery was not an indication for the father. So between them, I think we decided the right treatment plan for each of them. Another example for the orthodontic surgery, the case of this patient. This patient came to me because she hated her smile, she heard her teeth moving down, and she told me, I don't like my profile, I don't have chin, and I need to improve my smile and my profile. So this patient, if we need to go for the surgery, as I said, my choice for the surgery, it's always to go for surgery first. That means try to go for the surgery as soon as we can. Always we need to go for the surgery as soon as we can in order to give the patient satisfaction very quickly and to avoid to have the patient very long time with the bad decompensation position. So in this case, the surgery first is not an option. Why? Because we have this retroclination of the upper incisor. So we cannot advance the lower jaw since we have this retroclination of the upper incisors. So we need first to procline the upper incisors, then we can advance the lower jaw. So that's first. Second things, we have this cant of the occlusal plane. So since I don't intrude the teeth on the right side, if I advance the lower jaw, I will create completely cant of the lower jaw as well. So I need first to correct the cant of the occlusal plane. I need to procline upper incisors, then I can advance the lower jaw. So look at the clean check for this case. It was very short preparation. only 24 aligners, 6 months. I ask to procline upper incisors and intrude the right side. That's it. So you can see on the right side, I ask to procline the 11 and intrude it a little bit in order to create enough space. For sure, the class 3 elastic is very important to help this decompensation. When we have one side intrusion, always we need to think about mini screw. We cannot intrude only one side without mini screw. So I use the elastic on the right side between the aligners and the mini screw. We intrude slowly the teeth on the right in order to have flat occlusal plane. This situation on the end of this phase, we have flat occlusal plane, good expansion, good position of all the teeth, exactly the same protocol as previous patient. That means we need to bond the bite ramps, the elastic, the bond, the buttons, and the patient go for the surgery. Before the surgery, we need to give the surgeon the template and the guide to tell them where we need to finish the treatment. So I give the patient the place, so the surgeon did this surgery, put the lower jaw in contact with this bite ramps, and we have this posterior open bite. So now the second phase, what is the second phase? It's only to extrude the tooth in order to close completely this posterior bite, and we finish the treatment in this final position. So this one is the refinement we did in order to close the space, and this one is the situation with the elastic and the cutout buttons, and here the final situation. Patient smile in the end of treatment. We can see the smile line, we can see the deep bite, we can see the profile, and we can see the x-ray before and after treatment. Deep bite perfectly corrected, and the patient smile and patient profile completely according of our treatment plan and what we expected. So if we need to summarize the surgical approach for the bite patient, first things, vertical decompensation not necessary for those patients. We don't need to intrude lower incisors. We should keep the lower incisors in order to make this rotation of the lower jaw. Second things, the early surgery and the short preparation, the key. We don't need to have fully preparation. No, we need to do the preparation only to delete the interferences needed to do the surgery. So we try to do the surgery as soon as we can. If we can go for surgery first, we do it. If not, we do really the short preparation we can do. The 3D simulation is very helpful. With this 3D simulation, we can give the surgeon the right position of the upper and lower jaw, and the surgeon can do very accurate surgery for this patient. And when we do that, we can have very accelerated treatment post-surgery. Because if we do this surgery and we start the ortho treatment very quickly, we have 3 or 4 months very high accelerated cells movement. That means we can change the aligners every 3 or 4 days during 4 months post-surgery. So if we start the treatment very quickly after the surgery, we can, in this case, use the accelerated treatment plan, and we can change the aligners very quickly, and in the end reduce the treatment plan for our patient. If we need to take a home message from all information we get today about the deep bite patient, first things, for growing patients, we need to start the treatment during the pubertal time. No need to do 2 phases treatment except for some functional problem or for some psychological and aesthetical problem. But as deep bite, we don't need to treat it very early because it's not stable and it's dentoalveolar correction. Second things, the most inaccurate movement with clear aligners, the vertical movement. That means the intrusion of the lower incisors and the upper incisors is the most inaccurate movement. So if we need to use it, go with the mini screw. When we have real intrusion, always we need to use mini screw. The bite ramps, the one included on the aligners or the one bonded by ourselves, are mandatory if we need to extrude posterior teeth, because we cannot extrude posterior teeth if we don't have posterior clearance with the clear aligners. The intermaxillary elastic, we need to use it by the right position and the right way in order to have the right vertical component for our patients. In short face deep bite patients, we don't need to intrude lower incisors if we need to correct the deep bite surgically. As I said, because we need to make the advancement and the rotation of the lower jaw, so we can in the same time correct the deep bite and increase the height of the lower face for our patients. So that's the only information I wanted to share with you today. We have here the QR code about all references I used during this article. I hope it was helpful for you, and now we can treat the bite patient with more effectiveness. We have here my Instagram account. If we need to ask any question, please don't hesitate anytime to do it. And if we have any question now, I have some minutes to answer with big pleasure. So I received some question. The first question, what elastic I use with TADS for intrusion of the anterior teeth? So for the intrusion of the interior teeth, we need to put the mini screw between 1.2, 1.3 and the other side 2.2, 2.3. And the elastic as size, I use 316. And as forces, I use 3.5 O's. We don't need high forces elastic to intrude the teeth. We need very light elastic, very light forces in order to intrude them. So with these light forces, it will be more than enough to intrude in progress the anterior teeth and to close and to correct the divides. Any other question about the conference or the debate? So it's no more question. Thank you very much again for your kind attention, and I hope to see you soon. And I think next week we have another conference about growing patient, and we can continue to talk about the growing patient and clear aligners, how we can manage in order to give our patient the best option and the best treatment plan. I hope you all very nice evening and good luck with all your treatment. Thank you very much.